sharing experiences, really important. Learning from each other, hearing from our expert speakers.
I want everyone to really take control of their health, because it's your body and your life, and if you're not in control of it, no one else will be.
Turns out that almost all pacemakers are completely fine to go through an MRI scanner.
Both septal ablation and surgical treatment show good results. It's safe, comparable.
HRT for many women is a lifesaver.
However, and it was a real shock, they told me I did need a transplant.
It's funny being a carer. You know, sometimes people don't take their medicines properly and you get cross at them. Why are you not taking your medicines?
I would say the next big stage in the development of this story was our understanding that this is, many people, a genetic condition. So it's a heritable and transmissible disease.
So some of the pros of genetic testing are that we can find a causative gene change in some people.
I'm Malcolm Finlay. I'm a consultant cardiologist at Barts Heart Centre. I specialise in heart electrics. So any abnormal rhythms of the heart, so pacemakers, ICDs, atrial fibrillation, all the other sort of atrial wobbles and ventricular wobbles that people get from time to time. Spend about half of my time seeing patients in the clinic and doing procedures for patients, and the other half of my time I spend developing new either medical tests or medical treatments, and that's with a bunch of small companies and some that I've spun out of the universities, both UCL, QMUL and Barts. So I kind of have a busy time, and then every so often on Saturdays I end up being on call and also giving a lecture at Cardiomyopathy UK conference. So I was just on the phone to my registrar now saying, for the next 45 minutes, unless it's a real problem, don't be afraid to cope. So I am delighted today to be talking about us to be asked back here. I must have made not too many dreadful jokes last year. I've been asked back to talk about diagnostic tests. And, frankly, half of medicine is nowadays, if not more, is diagnostic tests. So I really wanted to go through kind of why do we do diagnostic tests, and then go through each of the key ones in turn. There may be some that, there may be some questions that you have about a specific test as we're going through. So just shove up your hand and shout out. I know we've got a format where you can write down questions at the end, and then we'll go if there's a topic that you particularly want covered, we'll fit that through. So there's plenty of time to go through it. So don't be shy about any of this. So I guess, why do we do tests? Why don't we just, like in the old days, get the patient in clinic, hear what they have to say, or sort of tell them what you want them to be telling you, and give them a prod and a poke, pee in a bottle, give it a sniff, and off you go with some tincture of iodine. So, I guess the whole point here is to move beyond the history and the physical examination to really understand what the true problem is and how we can really help it. So with the diagnostics, one thing that attracted me to cardiology is actually we have that. In most of medicine, I was just reminiscing with a friend last night when I was in medical school in the 1990s, there was a lot of guesswork. And I think there still is in some specialties. People come into the hospital as a doctor, one sort of sees a patient, you have a kind of hypothesis, and you say, well, I think this is pneumonia. And you say, well, I heard my stethoscope, I'm not sure whether it's working or not, but maybe there was a crackle there. And so I have these antibiotics, and if they don't work, come back in a week and then change the tablet. And you have this sort of cycle of treatment. It works kind of okay, but actually the world's moved on. And now I think there's this idea that we really need to, if you get the diagnosis, you can get the specific treatment. We've seen that, recently, and the most stunning manifestation of that has been in the treatment of cancers. Now, where you have people who are there, literally, so nothing you can do. It's time to say goodbye to everyone. That's it. And then actually there's one last thing that's just come along that we can try, and then sometimes you see things dissolve away, and people, I can give you anecdotes about he's a patient, I was going to say a friend, he's also a friend of mine who I I thought that was the last I was going to hear of him. And his wrote me a beautiful email saying how his cancer has got completely better and he's back to having a full enjoyment life again after stage 4 lung cancer. I mean, it's really, and that is because of the precision diagnosis allowing precision treatments. And so these tests we do aim to get there in different ways. And today we're talking about hearts. I guess hearts is one thing that we all, well, everyone has a heart, right? Everyone's got a heart who's around here. But interest in heart disease is why we've all come together today. The other thing that is important just to say is that although once we've got a diagnosis and we start down treatment, really the tests it's not often the way we feel is a good indicator, is a great indicator to how well things are going. But for prognosis and to work out whether this is something that's had a great response or whether we need to do some further treatment, then that monitoring of treatment can be super important. And one thing that's happened in the last 5 years to 10 years is that monitoring, I think, has become far less doctor-based. I think most people in this room, anyone wearing an Apple Watch or Fitbit or heart monitor of some description? Yeah, I mean, I'm not actually. Mine's in my bag, which is. But now, like we as people with a heart condition have the power to monitor our own hearts, not just devolve that to a doctor who may get a little snapshot every 6 months and look at it 6 weeks later and may not have may have lost it somewhere along. That power is now with us, and so we have the ability to put our own to look after our own health. And I think certainly me and my family have found that super important. I'm sure you have as well. Okay, so that's the sort of philosophy bit done now. All right, now let's get into the meat of things. Which cardiac tests are we going to talk about? So I just thought I'd split them out into, there's ones that look at stuff, or the imaging tests. Most of us have had some of these tests, and then there's ones that look on the other side at the stuff that happens. So like the physiology. So that can be the electrics, how the hearts are, really working. We can have the blood test, what the hormones are doing, how the body is generating, and deficiencies we may run into, as well as things where we actually, not just looking at what the static picture is, but actually stressing the heart. That could be some of our invasive tests, and also some of our physiology tests, like the exercise physiology tests. And they're I think quite exciting actually, how they are becoming more and more important and tangible in the way we can make decisions and diagnoses based on those. I don't know about, everyone's got a different experience, of course, but classically, we will do tests when people are sitting or lying in the clinic. And yet, symptoms of heart failure or breathlessness aren't when you're sitting in bed or lying down at rest. They're when you're rushing around the Sainsbury's or hoiking up 2 flights of stairs because you've left something under the top of the house. So being able to do tests whilst the heart, or whilst the body is under those extra oxygen demands, and the increased understanding, I think still is a sort of frontier of our knowledge. And although we've dabbled with that for decades and decades, really that move from a sort of phenomenology to really understanding what those tests can bring us is at the forefront of some of the things that we're seeing now. Okay, so I thought I'd just put a slide in. What tests do I think are the most basic ones that every new heart patient really should get the first time you see a cardiologist, almost no matter what, right? So the basic ones, I think, can't go wrong with an ultrasound scan of the heart, an echocardiogram. That will show what the pumping function of the heart is like, and it will also show if the heart valves are working. Pretty much, and it will show any funny business. So if there's if if there's something unexpected that we've read about in the back, in the little footnote in a textbook, it'll probably show up in the echocardiogram. That's kind of cheap. I mean, I was going to say it's cheap. It's as expensive as the contract on the machine and the person's time, who are paying for the expertise and time of the person interpreting the scan. So it's kind of not one of these massive whizzly bang, $2 million installation cost systems. This is kind of a inexpensive test that even a basic echocardiogram that you could do in the emergency room gives 90% of what you need to know for the cardiac, for the future diagnosis and treatment. That coupled with the ECG becomes incredibly powerful. So if you have a normal ECG and a normal heart exam, like listening with a stethoscope, me prodding you around, blood pressure, that sort of thing, and a normal echo, your life expectancy is basically unlimited. That's not quite true. There could be something going on. But let's say you turn up and you say, whatever symptom you want, like the chances of there being anything super nasty going on there is super low. It is super low. So as far as a reassuring, particularly for young people with young person with palpitations not feeling quite right, these are super powerful tests. Of course, often we then will pick up a really strong strand of our diagnosis. And actually, with this little battery of tests, making sure you don't have something wonky going on in the bloods, your hemoglobin's up to speed, your ECG is, and your echocardiogram, just with those three kind of chunks of tests, everything else is a little bit nice to have. I mean, these are the ones, if I had to run a cardiac clinic, which I kind of do, but just between you and me, if I only could have three tests, these three would be the three that I'd pick. All right, so a couple of things about echocardiograms, right? So of course, we use ultrasound, so they're pretty clever echoes. So that little probe at the end is not just beaming out one beam of ultrasound. That little square has got a grid of around 64 tiny piezoelectric transducers. And essentially, when you put a high voltage through a piezo transducer, this tiny crystal, it will vibrate at kilohertz levels, so megahertz levels, so about 3 million times a second, like this buzz. And that gives that vibrates the water molecules in your body because it's pressed against there. And those little vibrations are reflected back at the speed of sound in water, which is pretty fast. And it's not just picked up by the little crystal that beamed it out. It's picked up by all 64, and they're usually 64 in the modern machines. It listens to all of them at once. And so then, because you've got some bit of 2D space, you can actually locate where, not just the time of flight, but actually where in the, not just the distance away from you, but where laterally that is coming from. And if each crystal beams at a slightly different angle, one gets a very accurate picture. So echocardiograms, when I started cardiology, there was a little single crystal on a little lever which was going flicking backwards and forwards, and you could hear it shake and then break, and they're super complex mechanical tool. Now these are solid state, and although the one I've got displayed is a fancy big machine, actually you have ones that can be entirely the whole thing in the little pod thing that you hold, and that can connect to your iPhone even. So you can do these scans are really has progressed. That computing power and the battery power has gone, and the development of these crystals have gone from something being super rare, super complex, to being something which can be mass manufactured and should be available across across specialties that deal with the heart. One kind of downside to them is their user dependence. Well, there's two, really. One is that you're trying to get beams through the chest wall. So you've got ribs, or most people have. You've got a bunch of ribs between your the surface of your skin and your heart. And you've also got the lungs, and the ultrasound doesn't get very well through air, and so that can reduce the quality of the image. So often they'll get you to lie on your side, take a deep breath in, that opens the rib cage, and you can get this little window through the ribs to get the view of the heart. Nevertheless, remember I said about all those different crystals firing one at a time? Well, you can imagine some of those are firing straight into bone or straight into the lung tissue. And so they're kind of lost. And so the image quality one ends up with is lower than you think it could be. Yeah, it's also having to go through all the different layers of muscle, and if you're a slender fellow or lady, that can be absolutely fine. But not everyone is, and so sometimes the images can be less good quality. The second thing is, this chap is wearing a stethoscope. He's obviously very, very keen to listen as well. But these are human beings looking at these images, right? I know with the world of AI, this may change because the computational tools able to assess the images we get are rapidly advancing. I mean, at a rate of knots. However, that human error factor, particularly in some, unfortunately, particularly in a few important elements. So you may have heard of one of the measurements we take with echo, the left ventricular ejection fraction, the ejection fraction. And, we say, people say, what's your, the ejection fraction's 45%. Oh, no, it's only 40. No, normal is like 55, okay? 50. So that's a bit of a reduction. It's not a disaster, right? But it makes quite a difference to our thinking about treatments if your ejection fraction is 35% as opposed to 40%, right? There's qualitatively a bit of a difference. And that comes from most of the clinical studies that were done on the various medications. So a lot of the medications have been shown to have an effect, and also some of the ICDs and so on have been shown to have an effect, a beneficial effect on people with lower ejection fractions, but less so on people with higher ejection fractions. So there's some important decision makings to be made. And if one has that human error involved, it's not a big difference one side of the line you fall on. So you really want exact numbers there. And that is a defined problem with echoes. Okay, one other advantage, unlike lots of things that medicine does, this is pretty pain-free, right? We're really good at saying this is pain-free, but the worst bit about this one is to wipe off the jelly that you've had in the, at the end of it. All right, so how do we get around that idea that we get, or the chest wall gets in the way? Well, that's what the transesophageal echocardiogram. So I've done plenty of these. I've never had one, but it's, not so fun. Why do we put patients through things that aren't so fun? Because the information we get from this is second to none. Actually, this is the highest resolution of any of our cardiac imaging, right? Which is pretty amazing. Better than MRI, better than CT scans, okay? This shows us really in enormous detail the structures of the heart, and so much so with great contrast. So we can see things inside the heart that we won't see with any other tool. So we can see if there's a clot sitting in the top chamber of the heart in people with atrial fibrillation. So quite often before people would have a shock, we'd do a test like this to make sure. So if people have an irregular heart rhythm, atrial fibrillation, one of the big worries with that is that they develop a clot in the top chamber of the heart. And so people have blood thinners. Nevertheless, if people are feeling unwell and they've just started on, they haven't started on blood thinners for long, you'll want to check that they don't have a clot in the heart before you give the heart a big shock and dislodge a clot and give them a stroke. So here we are, general knowledge quiz. British Prime Minister who had a transesophageal echocardiogram. Tony Blair, absolutely right. Yeah. So I'd swapped my on call that night. I missed a bullet. So I was meant to be on call at Hammersmith Hospital. And the story goes that the staff nurse in charge didn't know who he was. And they were doing this they'd give him all the antibiotics, and she was there saying, "Come on, Tony, wake up, wake up," and kind of giving him slaps to try and wake him up. The Secret Service were all kind of. So it's extreme. Little anecdote aside. The TOE is he's been, I should say, he's been a super advocate of cardiac tests and treatments. I think both when he was in office and afterwards, and very open about his cardiac treatments. This little diagram shows the tube. You swallow it, and the esophagus swallowing tube runs right next to the back of the left atrium. And so the ultrasound waves hardly have to travel any distance, just a centimetre or two. You also have just soft tissue of the esophagus and the very thin heart border. So you get marvelous images of the heart valves. You get marvelous images of the of those top chambers to see any clot. You get pretty good images of the bottom pumping chambers too. It's quite a difficult test to do. Right, you have to swallow a tube. It's not very nice. You have throat spray. You give a bit of sedation. Sometimes people need a general anaesthetic to have this done. There's a risk with anything you do. No matter, this is super safe, but safe does not mean risk-free. There are reports where people have had a problem with their esophagus, and you put a tube down this, you could even damage the esophagus. And although extremely rare, that can be a pretty nasty thing if it happens to people. So, it's a great test. It's got its place. If it's needed to be done, it really is second to none. However, it's only reserved for those particular niches and needs. All right. The other thing that doctors do is blood tests. So I just thought, what blood tests do we generally do, and why would we do them? Would be of a little bit of interest, right? So people say, well, in America they say, let's do the full blood, let's do the full blood work, right? And this is kind of what they mean, the full blood work. And they can charge for every single one of them. So fair enough. So the hemoglobin, right? The red cells and the levels of hemoglobin, the numbers of red cells in the blood, essentially, not quite, but the amount of oxygen carrying capacity in the blood. If that's down, if the hemoglobin is down, you're anemic. Then, as a heart patient, your heart's going to have to be working harder. You get cardiac symptoms with mild heart disease, of which is of really no significance. If you've been bleeding from, for example, if you've got a bleeding polyp in your bowel, you can really, I had a patient whose hemoglobin was dropped to 6. She presented to me because she was having chest pain and abnormal heart rhythms. That hadn't bothered her until her hemoglobin dropped. Actually, the solution for her was a gastroenterologist to take out her bleeding polyp, not for me to treat her heart rhythm. And everything got better. If you have an infection, your white cells will rise to fight the infection. Also, that can happen in some inflammation. There are some cardiomyopathies which have got their underlying cause being a viral infection. Others which actually have a inflammation of the heart muscle directly, a cardiomyocytis. And sometimes you can see those white cells rise. To be honest, it's hardly ever the case in standard, in a standard cardiac diagnosis that the white cells will be related to the heart, right? That's usually a bystander infection. So if someone has a pacemaker or an ICD, a cardiac device, and that gets infected, obviously we'll be looking at the white cells for that. Okay, kidneys, that's the creatinine and urea test. Also secondary, the electrolytes, things like sodium and potassium, magnesium floating around in the blood. Kidneys and the heart work together. Like most heart medications, saying them can damage the kidneys, but are also used for kidney conditions themselves. And actually, a lot of what we think about as being a heart problem is actually a heart and kidney problem. And that can be because the kidneys because the heart pumping function is reduced, the kidneys try to conserve as much water as possible, or boost up the blood pressure with the hormone feedback. So the heart has to work harder, but it's not working so well, and you're conserving all this water. And so the heart goes downhill, and you start swelling up with fluid. So you have to then give diuretics. So it's all linked together. And monitoring that kidney function is critical for not just the monitoring is critical, the diagnosis is critical to make sure you're not missing something. Liver function. So, I mean, why am I really concerned about liver function? Just because I care about the liver? Been drinking too much? No, sorry. No. Yeah, that's it. Have I screwed up? A lot of the medicines we will give people have here's good medicine for you. Actually, it's poison, right? It's just getting the right dose. And so there's medicine that we use in heart rhythm problems now and again. It's called amiodarone, which can be really nasty on the liver. It's rare, but can be really nasty. So likewise, statins can affect the liver. So pretty much, everyone or their dog is on a statin, right? So liver monitoring is important for that. That's because the liver's the organ that gets rid of the toxins and breaks down all the toxins. But sometimes it gets a bit too much for it. Okay. BNP. I'm not talking. I know we're kind of East London, but I'm not talking. I'm not talking about. Some aggressive boys. So brain natriuretic peptide. Yeah, why am I looking at something from the brain? Well, typical scientists, they name it before they know what it's about. So the scientists who are looking at these hormones that natriuretic, things that conserve sodium, right? Things that make you pee, basically. And they isolated this from the brains of their rats. I mean, rest in peace, little rats. But this whole work was done until they discovered some other ones called atrial natriuretic peptide. But it turns out that there's way more brain natriuretic peptide coming from the heart than there is atrial natriuretic peptide. So this is one of the hormones whereby the body can regulate how much, what the fluid status of the body is. And why is that important? Well, if the heart's under strain, that can increase. That's hormone can rise, and we can use that for a kind of broad brush diagnosis or monitoring of heart failure. Now, it's not very accurate in that, it's not very specific, I should say. So if people have a raised BNP, that doesn't really tell us whether they are actively having heart failure, let's say. But it can be quite a good monitoring, and it can be an indication that the heart's under strain. So it's one of those ones that in specific patients we will run there and on, now and again. Interestingly, people with some cardiomyopathies, like hypertrophic cardiomyopathy, BNP can be very raised without it having any real new indication of disease progression or prognosis. So even though we've got a test that is associated with one thing, that doesn't necessarily mean that even if it's raised, there's a problem sitting there. Okay, troponin. Have anyone heard of troponin? Yeah? It's one of those ones that you go into A&E, you say, oh, I've got some chest pain, and someone's already taken a troponin, running that. So troponin was the darling of cardiology in around the 2000s, right? This is a part of the heart cell, which actually with the little myosin and actin filaments that pull together to cause a heart to beat. This is the little runner that helps them pull together. If you have damage to a heart cell, that gets released into the blood. You can imagine that there's normal levels, which are, varied between the different assay. But if there's some heart muscle damage, the cells are raised. The most common cause of heart muscle damage is a heart attack, blockage in the heart artery causing downstream ischemia. So when I was at medical school, basically the dictum was troponin is this amazingly specific test for people having a heart attack. Turns out that was wrong, right? So it's actually really specific if you have people who are having a heart attack to say whether or not they're having a heart attack. What it's not good at doing is taking other people who have a background heart condition and telling us specifically, is this a problem in the heart arteries causing a heart attack? So a lot of people still come through the DGH, have their blood with let's say, a chest pain problem, and that could be from a fast heart rhythm, could be a chest infection, could be anything, given they could have a background of having for example, a hypertrophic cardiomyopathy, and a blood test is run, troponin is raised, and lo and behold, people are giving you aspirin, clopidogrel, Clexane injections, even though this is not the treatment for the chest infection that you actually have. So it's like all these tests, it gives a bit of color, it adds a bit to the picture, but is not the be-all and end-all of the of heart diagnoses. And very frequently, I find patients with heart rhythm problems, atrial fibrillation, that can give chest pain. That also makes the heart race quickly, puts the heart under strain, and poor heart cells, a few of them can't be, a few of them give up the ghost. It's no big deal, but that causes the troponin to rise in the bloodstream. That gets detected, and lo and behold, you have them coming under coronary intervention doctors who want to put a stent in them, even though that's not really needed. So I guess, why do I harp on about this? It just gives you an idea that not every test which is marketed as a specific test for this condition gets it right all the time. There are exceptions. The other thing is the thyroid. Not only do medicines mess up the thyroid, but thyroid function, abnormal thyroid function, can mess up the heart, either making everything get sluggish, make everything get too active, putting people into abnormal rhythm. So that's the other one that I generally test all the time. There are others, but once you've got those, that's that's 99% of the major cardiology blood tests. On a ward round, they're the ones I'll ask for. Okay, some now advanced imaging, cardiac CT. That has come on a hell of a long way. So, anyone had a cardiac CT here? Yeah, it's go through the donut. It gives an amazing picture now of the heart arteries, right? So it is fantastic at showing whether or not whether the heart arteries are normal. And it sees it directly. Until 10 years ago, that was really just done by an invasive test. That means that, because then it's essentially completely safe. Sure, there's a tiny radiation dose. Sure, some people get allergic to the contrast, but pretty much it's a safe test, okay? And that means that rather than us giving a likelihood guesstimate of whether it's worthwhile, risks and benefits, someone having a direct angiogram, we can actually work out whether a heart artery disease is the cause of the heart muscle problem, for example, directly with just a CT scan. It doesn't give great images of the heart valves. It doesn't give great assessment of the heart muscle pumping function, though it's kind of coming along. And the reason why it doesn't give great assessment of the heart muscle pumping function is that because it uses X-ray radiation, it has to go right the way round in essentially in one heartbeat, but it can't move that fast, so it gates it to the ECG. So you get wired up to your ECG dots, and it goes, takes pictures, takes pictures, takes. So one little section every heartbeat, and that just takes that part of the heartbeat every time. So the pictures of the heart arteries then are not moving; they're nice and still, right? So you can interpret them. if you want to see the heart beating, you're going to have to take right the way through the different parts of the heart cycle. And so the X-ray dose gallops up quite dramatically. So there are fancy ways of doing this now, and I think that's kind of coming, but it's not really a functional test. You can think more of it as an anatomy test in the way it's being used today. You can imagine if you have an abnormal heart rhythm, which is irregular, then it may be less accurate. If you have things around your heart which stop the X-rays getting through, so for example, if you've got a heart valve before, if you've got pacemaker leads, if you've got a stent in one of the heart arteries, well, the X-rays don't get through that so well. And so you get artifact, and it's harder to get a really solid picture, a really great picture of the heart artery. So sometimes we'll do a CT scan and say, well, there might be disease there. We need to do another test, a direct angiogram, to really see if there's a problem in that heart artery. But if it's normal, you can be really reassured that it's normal. Here we go. So cardiac MRI scans. This is a wow, a picture that works. This is yeah. So, I mean, cardiac MRI scans. I was joking with a colleague of mine, like the same person I was talking to last night. Like, why are there so many cardiac MRI scans done? I mean, this in the 2000, like, anyone had a cardiac MRI scan here? Yeah. I mean, you know, anyone love it? Oh. Yeah, I had a dreadful time. I hated it, you know. Put into a tube, it's like you're dead already, right? It's be shot into outer space. You know, you have the heart, it gives pretty good images of the heart pumping function, right? It gives really good images. But actually, those images aren't any better than echo in many ways. They can be interpreted, let's say, in a little bit more precision. So in some patients, you know, remember what I was saying about, you know, the human interpretation error that we get in echoes? That's less in cardiac MRI scans. You also have that you don't have this problem with the ribs in cardiac MRI, you know, and so you can pretty much get a good image, you know, in everyone, well, everyone who can lie flat in a tiny tube for 40 minutes, not feel like they want to run out screaming, you know. Everyone who doesn't get deaf because they're in the background, you know what I'm talking about. It's there are these worries about having MRI scans as well, because a lot of people who we think would benefit most from an MRI scan are told they can't have an MRI scan because someone like me has put a pacemaker in them. Turns out, actually, and I have to give some of the guys at Barts incredible credit for this, turns out that almost all pacemakers are completely fine to go through an MRI scanner, even the ones that are told not to be safe, right? So it's this kind of cardiac devices, it's not a myth. I mean, it's done with best intentions, right? We've seen these pictures of, you know, IKEA chairs flying through the room into the MRI scanner. And you know, it's a reasonable worry that these things wouldn't be great if that, you know, your pacemaker flew out your chest. But in fact, most of these metals have got very, very little ferromagnetic material in them. You know, it will mode switch, so it won't function as intended with you know, in the MRI scanner. You know, usually devices would go up to a backup rate or backup system, which in some people might give them symptoms. But, you know, when they looked at, you know, there's hardly been any instance in all the people who have been put through an MRI scanner by accident without realizing their things. And so actually at Barts, they will support people having MRI scans, and they will support people having MRI scans who need them for other parts of the body. Because frankly, there's nothing that can see the brain like an MRI scan. There's nothing that can see an ankle or a hip like an MRI scan. Even for ICDs. Even for ICDs. And even for ICDs that are said to be not compatible for MRI scans, there can be specific programming done, which will make that makes it safe. And like I said before, the phrase is safe is not risk-free, but that risk is extremely small. Yeah, so another great question. Old leads, once again, old leads by dictum are not safe. Turns out they are not risk-free, but they, in most cases, are safe. So it turns out to be a risk versus benefit equation. There can be some times where people really don't need an MRI scan. You could do things with other modalities, as we've shown before. There are other tests available for many things. But when people need that, and there are conditions where you just need an MRI scan, it can be done, and they will support that. They will support that through. And there's a website, I think it's called mymrisafe.com, mymrisafe. And that, if you type that into Google, the right one will come up. And that will give that's kind of a way that you can get directly in touch with the group at Barts to work out, to at least get the support around getting an MRI scan.
It's a slight myth with MRI scanners. What about airport scanners? Is it now okay to go through the security thing? Sorry, because we're recording it, if you're going to talk at any length, you really need to have that.
Oh yeah, so just to say the question, which was sure. So the question was, what about going through MRI scanners? What about going through the security scanners at airports? Okay, so it's almost certainly going to be fine, but there's no benefit to you to going through there. Really just get done with a peeper. There has been a few case reports of the magnetic fields in some of the scanners making some of the devices fooled into thinking the heart was in an abnormal rhythm. And there was one case where someone had a case report where someone's had a shock from that, right? So, they're not, and then it's not a great place to have that. And then, if that happened to you, you'll miss your flight for sure, So I would recommend sticking to the guidelines for that. Right. Okay. So, so one thing I haven't said about, didn't mean to be derogatory about the MRI scans, even though too many are done really for what's really needed. They are really great at looking at the heart muscle. They can really make diagnoses of the heart muscle that no other test can make. So for some cardiomyopathies, the MRI scan as a diagnostic test is the one, let's say. And if you have cardiac inflammation, particularly, some diseases of like sarcoid, cardiomyositis, these are seen on MRI scans with very specific patterns of scarring, which one can't see with other tests. So it has a critical place in cardiology, even though many of the scans that are performed can be, other avenues of treatment can be, other avenues of diagnosis can be made. All right, let's. We've been going for about 45 minutes. You must be bored stiff, and lunch is waiting. So just going to fly through a few other things. Coronary angiography. You remember I said of the CT angiogram, there's something in the way that you don't see it. Well, the next step is putting a tube up the arm, up the radial artery, and squirting dye down the heart arteries. And the great thing about that is once you're there, if you see something, oftentimes you can put a stent in and unblock it. Well, the same job. So that's, CT's taken over from the pure angiogram, but it's still a major part of the precursor to putting a stent in, or if people need that decision between stenting or cardiac surgery. Okay, cardiac ECG monitoring. Well, here's a little anecdote. You might have guessed I like a few anecdotes, right? This is a nice one, right? A bit of history lesson. Augustus Desiree Waller, physician at St Mary's Hospital in the late 19th century. And he invented the ECG. And his contraption is he essentially used a couple of saline buckets to connected to a column of mercury and then sulfuric acid. Sounds very safe, doesn't it? Don't try this at home, kids. And then he had a slit in the window with a beam of sunlight going down and a toy train, a Hornby wind-up train with a photographic plate on it. And then just at the right moment, you let the train go, and then it would trace over the shadow of the little meniscus vibrating in between that, and that gave this sort of black and white kind of image. That was the raw image. And from maths of knowing about the viscosity of sulfuric acid and mercury mixture, as we all do, you can work out what the electrical voltage change was. And that was the first ECG. And, he was a bit skeptical about his invention. He said, I do not imagine that electrocardiography is likely to find any use in the hospital. It can be rare and occasional to afford some record some rare anomaly of cardiac contraction. Of course, most anomalies then were pretty rare because people didn't last long enough to have one of these tests done. But he got into some trouble because he went around, demonstrating this. And you can't just get someone to sit in the bucket of saline. So he got his bulldog, his British bulldog, trained it to stand in the same, in the pots of saline, and it was the same. Yeah. Well, it's like one of those dogs. Yeah, the sort, but it was a tame one, and he got into trouble because at that same time the sort of Cruelty to Animal Act was being brought in. Because another physician in UCL who had been misbehaving, right? When collecting stray dogs, actually, and doing experiments on stray dogs, and turns out they weren't actually strays. People were out for a walk and had sort of snipped the lead, and so they, the residents of Hampstead Heath got him into trouble, and it was brought up in Parliament, and they said, well, and Gladstone defended him, saying, this is, the honourable member for Southend or something was saying, this is dreadful. He's getting a dog to stand in these chemicals and with a collar on his neck and wiring up to this contraption. It should be bad. And Gladstone said, no, this is it's no worse than having your dog go for a paddle on a summer's day by your beach. And here's a picture of Jimmy the dog in. Next to everyone crowded around this bizarre contraption projecting the light to see Jimmy's cardiac contraction. And because of all that controversy, things got swept to the Netherlands, where a slight improvement, something called the string galvanometer, rather than using all that acid floating around, they used a little silver wire. This was Eindhoven, is sporting the various... Do you remember that Gamma ruffler fish stuff that would you nibble the hard bits in your toes about 15 years ago? Well, the precursor to that. So that's Eindhoven. And then the ECG improved, of course, over the years, little by little. And there's one of the original ones in the Science Museum. And the big advantage of this was the first commercial ECG machine. And the big advantage here was that you had some wheels on it. So now you didn't have to bring the patient down to the department. The ECG machine could be brought up to your patient. So cardiac monitors have come a long way in the last 100 years. Really the point of having a heart monitor is to get symptom arrhythmia correlation. Yeah, so to work out what symptoms are happening. And of course we have the 12-lead ECG, which is the standard kind of ECG. Anyone know how many leads we have in the 12-lead ECG? Well, there are 10. Yeah, I know. There's 10 leads. You've got 10 things, and 2 of them connect together. So you get 2 for free. Okay. But this has gone on from being things which are just that snapshot ECG to being monitors for 24 hours to being then these monitors that we all wear and being able to pull out an ECG all the time with a smartwatch, for example. And these are fantastic. because you need to get, the real thing is, with these ECG monitors, what is the heart rhythm doing when you have symptoms? Because if you have a blackout and you're wearing an ECG monitor, well, then you can look at the ECG monitor and say, the heart was doing that when this person had a blackout. If I do an ECG monitor, and I tell you what, nobody ever gets real symptoms when they're wearing an ECG monitor, right? Because you don't do the stuff that causes you to have a blackout when you're wearing the ECG monitor. So they've got a super low pickup rate. So people having their own ECG monitors, their own smartwatches, is a huge advantage. Sometimes, if you black out, you haven't got time to do a monitor recording because you've just blacked out, right? And so implantable, that's the next slide, implantable recorders, the loop recorders, these are incredible things, like the size of a pen lid, injection in the outpatient clinic. You've got 3 years battery life in that. Now they can communicate with your smartphone, full 24/7 monitoring. They are superb to work out whether people are having abnormal rhythms, either slow rhythms or fast heart rhythms, whereas in the past we were a little bit guessing which way to go. So they've really changed management. I'll just come to the last few things, the very last things to say, because we've got 5 minutes for questions. Exercise testing. So cardiopulmonary exercise testing. We used to have the treadmill tests, right, where you'd be on the treadmill. That was pretty dreadful because it only looked at the response of the heart ECG. But now the cardiopulmonary exercise testing really looks at not just the ECG, but the whole body's response to being under stress. And that really is the under exercise stress and demands for oxygen. They're complex tests to do, they're complex to interpret, but their utility is becoming more and more apparent. I think, as far as a way of monitoring treatment for cardiomyopathy, it's not suitable for everyone, but it is, becoming more and more useful for determining people's actual objective functional ability. I couldn't do all this without saying one other study. There's some ugly guy doing some work there. The electrophysiological study that this is not a common test that is done for most people unless they have specific heart rhythm abnormalities. And essentially you pass wires from the top of the leg to the heart and stimulate and record the heart rhythm from various points inside the heart. And depending on the heart's response to those stimulations, you can kind of work out whether there's an extra pathway in the heart, whether there's some extra circuit that can trigger abnormal rhythms. And I can do treatment immediately after the same sitting. So for some forms of SVT, that's super useful. That's like the number one test. For most other general cardiac conditions, this is not really generally used. Okay, I was going to give you a couple of slides on genetics, but we could just go on and on and on, and there are other far more qualified people to talk about genetic tests, and I think that really is highly specific stuff and not part of our general cardiac test. So, in conclusion,
thank you so much.
There we are.
So I have one question.
Go ahead.
Written here, which is probably as how long as a piece of string, but the question says, and by the way, while I'm doing this, please think of your questions. This person has got HCM, and the question is, how often should I have monitoring tests?
Yeah, interesting. People generally do an echocardiogram in an arbitrary manner for these things. So the absolute frequency will vary on individuals. If someone's felt to have a cardiac valve which is they may need urgent replacement, then they may get echocardiograms even every few months, right? However, most people will have intervals of maybe a year, maybe more, even in quite severe disease monitoring, unless symptoms change. The other thing is, I think with our own monitors, that gives us an idea if something changes, we can alert ourselves. And so that patient-initiated follow-up can be super important. So a background interval test, plus that ability to bring things forward if some symptoms chest seems to me to be a good way forward.
I mean, the role of the patient in monitoring themselves is growing.
I mean, it's
Massive.
gone from being something very low to being front and centre, and I think that changes the whole relationship, the whole way we do all these
We've got
practice medicine, really.
Just if you wouldn't mind, your mic.
I'm not sure that this is a very useful question, but I've always wondered what the point of the sound in echocardiogram.
Oh yeah,
because I hate it.
Oh right.
It
really cuts you through. Yeah.
And I said that to somebody once, and they just said, "Oh, just switched it off then." So I kind of thought, well, what's it there for?
Yeah. So I think it's when you're actually doing these tests, so basically that's an interpretation of the Doppler flow. It's not actually a recording of the sound. So it's like an electronic interpretation of what that flow looks like. And you can hear that subtle changes in that frequency slightly more easily than one can see it on the screen. And so if you imagine they want to get the beam that they're looking at the flow of blood through the valve just bang on in that center. And so you can just hear whether or not that's just hitting the right spot. So it's a little bit easier.
So we've got a question over here from this lady.
You were talking about people self-monitoring. If people are thinking of self-monitoring using an Apple Watch or something like that, does it have to be a watch that talks to other equipment that you've got, like your phone, or is it an entirely independent? Because I know that Apple doesn't get on with Android, for example.
Yeah, true. So, So first of all, the watches that really do good monitoring all have an ECG in them. The ones which you have two levels. One, almost all these things will do one, like some pulse oximetry type blood, pulse rate monitoring. But it's actually the ECG monitoring that really differentiates those medical ones. The Apple, the Samsung, the Fitbit, these are all excellent devices. They all have their own non-compatible ecosystems. I think the Fitbits work with most stuff, but they do tend to make themselves affordable by offloading all the computation onto the phone. So it kind of works as a unit. So if you have Android systems, I wouldn't go down the route of an Apple Watch because, frankly, the Fitbit or whatever they call it, the Google Pixel Watch, can do the job just as well.
So we've got time for just one more question, if that's okay. So
and I should say I'm available afterwards if anybody.
That's wonderful.
So I haven't had a call from the hospital saying help.
I understand from earlier talk that HCM is more likely to lead to heart failure, or you're more likely to get heart failure if you've got HCM than the background population. If that's the case, should people with HCM have CT scans regularly to identify potential coronary heart disease problems?
Well, CT, yeah. Actually, the heart failure one tends to get in hypertrophic cardiomyopathy isn't necessarily, it isn't necessarily going to be picked up on routine CT scan monitoring. I think you probably want to, once again, if there's a change people notice, that's the time when things are important. Now, screening CT scan is kind of important. You could argue in a high-risk population, that can be the thing to do. But frankly, if you're on good medicine, your blood pressure is controlled, you're not smoking, you've got your cholesterol under control, with a statin, then the risks of developing like severe coronary disease are really plummeting down. So if you manage the risk factors, I think just hoping that a scan will detect whether or not we're going to do something, that's not quite right. One just reminds me of a very, very, do you know that dogs can't have MRI scans? No, because cats can. That's it. That was almost Christmas. Come on, there we are.
I was going to thank you very much for this one. Thank you, Malcolm.